Hi there, good evening, and welcome to AMDA COVID Grant Ones, Pearls from your colleagues. I'm Sabine von Price, your host. I'm from the Washington State AMDA chapter. Just when we thought that the urgency for COVID grant rounds webinars may have slowed down, so much happened. CDC is changing the recommendations on length of transmission-based precautions again, and we are finally seeing some data on viral cultures. That is and the science that is maybe behind these recommendations. And I was going to, we were just discussing a paper on racism that was in COVID in long-term care, or the racial disparities of COVID in long-term care, but we have removed this paper because we will reserve this for a separate discussion. However, we all got a gift last week, a big gift from Mr. Trump, SARS-CoV point-of-care antigen testing for all. Lots to review, lots to discuss. If you have patience to discuss, if you have questions around that, feel free to bring that in. We are so pleased to have 3 experienced post-acute and long-term care leaders join us today to discuss the evidence in the literature that is pertinent to our patients and will deepen the understanding of this disease. We asked them to highlight their favorite COVID articles. Dr. Irene Hamrick, who is now Chief of the Office of Geriatric Medicine at the University of Cincinnati, and prior to that, she was the Medical Director of the University of Wisconsin Health Long-Term Care Facilities Program. We're so pleased to have you. Dr. Arif Nazir, of course, needs little introduction for this crowd. He is the immediate past president of AMDA and chief medical officer for Signature. There are many other attributes he has, but we're going to keep it short. And then Dr. Jose Pinion, aka Chelo, is an experienced medical director, former hospitalist, and currently senior vice president of medical affairs for American Senior Communities. Welcome, Chelo.
Thank you.
One of the things that we have learned during these webinars is that the chat function is one of the best tools we have for you to share information with each other and address your very specific questions and concerns. So please use the chat function actively today. And I really apologize. I'm making all these mistakes today. I don't know what it is. It's probably the weather. The sunshine that we finally have is confusing me. So to get us kicked off, let's start out with a couple of polls. Aaron, bring on the first poll, please. Based on the new CDC guidance that recommends removing transmission-based precautions using a symptom-based strategy instead of a test-based strategy, what do you plan to do? Continue to use the test-based strategy until more data is available? Move to a symptom-based strategy as the CDC suggests? Use a combination of both test-based and symptom-based strategy, or not sure yet? Go ahead and submit the answers to this question, this question, and you have about a minute to do so. This is an interesting result. So the majority are moving to either symptom-based or a combination of symptom and test-based. Some of us are not sure yet, but really very few continue on a test-based solely strategy. We'll talk about that in one of our articles. Let's go to the second poll that we will also touch on with one of our papers. Big question. If a patient had COVID-19 a month ago and tests positive after having tested negative, we have all experienced that. What do you think is going on? Patient got reinfected. Patient is still infected and previous swab was false negative. Test is false positive. Or patient is shedding virus fragments that are not infectious. Go ahead and submit your answer.
Great.
Well, I think I think the answer, if this is a Delphi panel, if this were a Delphi panel, I think we have our answer here. Let's go ahead and look at some of the papers that our audience brought. So Irene, shall we say ladies first? And Irene actually has broke with a month-old tradition, not bringing any slides. She is bringing slides, and we thank you for it. So go ahead, Irene.
Okay, go ahead and bring up the first slide. So the CDC came out with these new guidelines, and I've only copied and pasted 4 of the bullet points of that. There are about 8 or 9 of them, and the others are not as earth-shattering. I was very excited to see the poll that you got it all right. So I don't think I need to even talk about this because you got the answer correct. So I think I can just pack up and go on. I'm not going to read through this because I'm going to address all of those in the papers that we're going to discuss. But these are for your reference, and also the link to the CDC is in the title. Go ahead and bring up the next slide with the papers. So virologic assessment of hospitalized patients with COVID-19. This was a German study that was done after the outbreak in Munich, where a lot of the skiers from northern Italy brought back the virus into Germany and then infected a bunch of other people. They had a very low mortality from that because those skiers tended to be young in their 20s and 30s. Yet they still got infected. And the virologists who did this study, the lead virologist is Christian Drosten at the Charité. And he then just took it for all it was worth and looked at antibody tests at PCRs, but also did virology and some contact tracing. And they found that the cell culture grew from about 16% of swabs and 83% of the sputum samples that they did. And that was done early on, so in March or even February when he did that. And it was first published peer-reviewed in March. So it was a very early study. So the testing was not as advanced as it is now. But they grew no live infectious virus from stool, despite of high RNA levels by PCR. And to that point, I just want to say briefly, there was an article that came out maybe a month ago saying stool is infectious. And I'm like, this makes no sense because it's contra to what I had read before. And sure enough, that paper looked at lots and lots of stool specimens, and what they identified as infectious were 2 microscopic identifications of virus. So they saw under the microscope virus in 2 subjects out of the hundreds of subjects that they looked at. But they did not do any virology testing. They did not do any contact tracing, none of that. So it was a false headline, and it did not go any further either. So I don't know what happened to that paper. But no virus was found in urine or serum samples either. And when they looked at antibody tests, the seroconversion, and this is the top graph in the right figure, the seroconversion started at 5 days, and 100% of people were seroconverted, so showed antibodies at 14 days. And we can talk a little bit more about antibody tests at the end if we have time.
I mean, may I ask you, so
Yeah.
What's your understanding of the patient population? You mentioned skiers, and unfortunately, I know some of these skiers personally that were
Oh.
infected, and some of them did actually do poorly. So what was the patient population? Was it at all comparable to our patients, or were they
No,
younger?
they were younger people. They were able to ski. You know, some of them were older, but still,
Mhm.
for the majority, they were much younger and much fitter than our patients. Absolutely.
And
Yeah.
did they relate this? So this study, I think, was cited in the CDC
Yes.
paper, right? So did they relate this at all to severity of the disease in here? I know you're citing a paper later where that is a
Right.
factor.
They did not look at severity, and I think there was not much severity in those patients.
Mm-hmm.
What worries me on this one a little bit is the fact that for CDC to use this, I don't know if CDC is using this one or not, but the 100% seroconversion is very quite surprising, because studies which we're seeing in US, we're not finding 100% seroconversion by day 14. Actually, seroconversion, most of the studies which I've read are mostly like the third week when you start seeing seroconversion, and it's 100%. So it tells me like maybe this is a younger population who are mounting a stronger antibody response, and maybe that kind of relates to not having any live virus by day 8. How would that manifest in our population, and particularly older frail patients? Maybe a little bit different. So just kind of point to think about the seroconversion of being 100%.
Yeah.
So the other big difference with the seroconversion and our test that we're doing in the US is that we're usually using the quick test to test seroconversion. This was done in the virology lab at the Charité, which is the premier European virology lab for coronaviruses, and they did ELISA. So it was the prime test. And of course, they had a captured audience that they knew exactly when they got infected, how long they had been infected, and then they did serial tests. So it's a whole different ballgame than what we have available. The other thing, since we're talking now about antibody tests, Germany started developing testing in the middle of January, and and announced an antibody test to come out in March. However, they delayed it until the middle of May because they said the quality is not good. And when it did come out in the middle of May, it had 100% sensitivity and 99.8 specificity. So much better than anything that we have available in the US. That's the other big thing for these fast tests. But what they did was a different test.
I was just going to say that's probably not this test yet.
No.
Jaylo, do you have anything to add or any questions about this?
No, I agree with Arif and Irene. These are young, healthy folks. I'm also curious what the N here, maybe, if it's not a very big N, it might be easier to reach that 100% seroconversion again in very young, healthy folks. So again, the applicability to our population is sketchy. And this is a little bit of my problem with some of the CDC data. How much of it is applicable? I know some of these are unpublished, and I'll reserve my comments for something later on when we talk about test-based strategy, moving on to the symptomatic. I did make some decisions for our company based on some of the lack of evidence that the CDC had. So I'll reserve it for later on.
Okay, great. The one thing that I wanted to say though is this may be applicable to some of our staff, not all of our staff, but those younger, healthier staff, this may be applicable into some of family practice outpatients. So, all right, want to go on with the next one?
Okay, so the biggest takeaway from this study here is actually that there was no positive culture that could be grown after day 8 or by day 8. So day 8 and later, none of the samples grew positive cultures. Yeah, next study. Okay. Viral shedding and transmissibility. This was a study out of Hong Kong that looked at the spread of disease and did extensive contact tracing. So infectivity started from days 2.3 before symptom onset and peaked at 0.7 days afterwards, and that was based on transmission pairs. So the highest infectivity, therefore, was the day before symptoms started, and then up to 5 days later. So for a total of 7 days, people were infectious and were able to transmit the disease. So this was a great study, and that it really looked at transmissibility, not virology culture, not PCR, if there is virus there or not, but if it is infectious. So peak infectiousness was at 2 days before to 1 day after onset, with the highest infectivity.
Sorry, Irene, could you?
Yeah.
What does that? What does infectiousness mean? I mean, how you measure it?
They measured contact tracing, so they looked at how many contacts got infected.
All right, so that was history based, basically.
Right, exactly, and test based. And in Hong Kong, they did extensive testing at the time because they had SARS-1 there. So as soon as they heard about China's outbreak, they started producing tests like crazy and were able to test anybody who needed a test and any contacts that were in contact with an active case. And that's how they kept it down so low. And the whole population was used to wearing masks from SARS-1 and never even stopped wearing masks since 2003 when SARS-1 was out. And that's why they have such low morbidity in those countries in Southeast Asia.
So this was contact tracing based testing.
Exactly.
That's what I'm hearing you
So
say.
who got infected and how
Okay.
long, and when was the highest infectivity from all the contacts they've had.
And do we have any age data there?
I don't think I included it. Let's go to the next slide because there's, I think, a graph on that. No, that was the other slide then. So I should have included the age into that. But it was all comers, not a lot of older patients included in that because that was during lockdown and older adults were just really locked down and very fearful of going out. So I think the average age was about 50.
Okay.
So this was the latest paper that just came out and looked at 106 samples from 105 patients. And they cultured the virus after and looked at when they, so they looked at the timing of when the cultures grew. 50 patients with mild COVID, 56 samples of 55 patients with severe COVID were tested. And of the 106 samples, 65 were obtained at diagnosis, so within the first 3 days of either symptom onset or contact, and they didn't describe that. And 87.7% grew in culture if it was obtained early in the disease process. And then 41 of the samples were obtained later in the disease. And in the mild cases, 36% grew up to 10 days by viral culture. So in the mild cases, when they took samples later on in the disease up to 10 days later, it grew culture. After 10 days, when they tested these folks, it did not grow. In severe COVID patients, it was a different story. So 56% had positive or had virus growing in culture within the first week, 60% in the second week, and 60% in the third week, so up to 3 weeks. And then there were 2 patients who also grew it at day 30 and 32. So there were 6 patients that were in ICU and 5 of them died. And those samples were taken by bronchial aspirate because they were intubated, so it was easy to access that. But the authors did not specify, and I looked far and wide for supplemental data or anything, but they did not specify if the samples that were obtained by bronchial aspirate were the ones that grew in viral culture for a longer period of time. Next slide. That's the graph of this study. So the blue dots are the ones with mild disease, and they only grew in culture for the first few days. And there was one that grew at day 10. So everything was pretty much done within 10 days, definitely 2 weeks. For the more severe patients, viral culture grew much longer than that, and definitely up until 3 weeks, and with 2 outliers for a month and a day even. So what I take away from this study is that I tend to isolate my patients that have had COVID for 2 weeks, but if they've had severe COVID, it usually takes them a couple of weeks to get out of the ICU and then onto the floor. And then by the time they come out, they're usually a month out anyway. But if they're not, I would definitely isolate them from my patients and from my staff and just be very cautious for a month in those folks.
Yeah, I think this is a very interesting study. Actually, I was hoping somebody would be doing viral cultures finally, because we haven't seen them out of the CDC. And this is a Spanish study, so it comes out of Spain, I think. And so I guess I looked at this. I had just decided actually 2 weeks ago, after our AMDA Pearls grant rounds up, when I was the only one still using test-based strategy, to move to time and symptom-based strategy, and to discontinue precautions at day 14. But when I saw the study, you send it around in your wonderful emails that you write, I thought, maybe I'm going to do this with a qualifier. And so then what our strategy is at Avalon now is, if people have been in the ICU or even hospitalized, we continue exactly what you say. We continue transmission-based precautions for at least 4 weeks. But look at day 20, we start looking at maybe discontinuing them and will use PCRs. For now, until we get better evidence. So
one thing I want to just mention here is that let's make sure that we do not automatically translate viral replication in a lab into infectiousness. Okay.
Exactly.
So,
that's what I was going to say. I was going to say we really need to look at infectivity and contact.
Yeah, which site is being produced at, and what length they went in literally to get the sample, and all those things are going to be very, very important. So, and again, most of the studies which I've seen again have been very short and very small, and they have kind of confirmed a very short time of viral replication. This is the first one which has gone that far, but again, it's a very small sample size, and again, who knows what it really means.
And my strategy is going to be ready to be completely revamped when the next evidence comes out. This just really concerns me. And as far as I think I read the study, and this virus did kill cell cultures, I think, when it grew some of these. So, but you're right. That is a different. It's a lab. It's not clinically traced for infectivity. That's
the reason. The reason I want to be a little bit of a devil's advocate is that, guys, testing of people and isolation of people is coming at a whole different price, right? It's not. It's one thing to simply say like, oh, we're going to isolate people. Like, man, we all know now what price patients are paying for that isolation, and what price staff are paying for that isolation. The PPE they have to wear, the resources which are being utilized. I don't know what gets ignored when you isolate people, in terms of providing them care. There are just so many implications of these decisions. So I just want to make sure that we kind of keep on looking at both sides of the aisle when we make those decisions. It's not that just being too protective of our patients does not have a price to pay. There's a price to pay for both sides. So that's why, I just want to bring that caution.
I fully agree with
That's
that.
what we said, we'll reevaluate at day 20. But Chilo, what do you think?
Yeah, so actually our experience, I will tell you, we started with the test-based strategy off the bat because we were very concerned that there was really not enough data that the CDC was putting out there to really defend why it's making these recommendations. For example, I think the blue dots here, which is the mild, was already available in a study that they mentioned back in May. There was an N of 14. That was 14 patients that they said that they couldn't culture anything beyond 10 days. And I just was scratching my head and I'm thinking, well, how can you make national recommendations based on 14 patients? I mean, surely, with all the testing positive right now, they could have at least increased that number. So I didn't feel very confident. We went test-based strategy all throughout. But you're right, Arif. We have, on average, had to go as far as 30 days just to chase that double negative because you need 2 negatives to really kind of prove that they're negative. And the isolation, the dehydration, and some of these patients were dying not even because of COVID, not because of respiratory symptoms. They were dying simply just because they were dehydrated, or they were lonely, they were depressed. It was almost tragic to see how, it kind of made you wonder what's really worse here. Yeah, they're COVID positive, but they could have been an asymptomatic COVID positive that would have gotten better. But now since they're isolated for a long time, now they've gotten more complications. Maybe their wounds got worse. They were falling more. Some of the QMs that we were normally very diligent about because of the isolation now kind of got laxed a little bit. And so, like Arif said, there's a price to pay. And isolation really, where's that balance point where, you want to make sure that they're not infectious, but at the same time, you don't want to isolate them too far out.
I fully agree. And, you were saying these are 16 patients, but it's out of 105 patients total. So this virus does not grow very well. And as we know, infectivity is about 15% even in households. And there has been no transmission that occurred with touch that has been documented. So surface contamination is really negligible. This is not like Ebola, where half of the people die that get it and it's so infectious. So, it's a whole different story. So we need to look at it in a bigger picture, just like you and Arif have said. What is the cost of isolating those patients? So let me go to the next study, and that is the Korean study that gave us that fourth answer on the multiple choice. And that's where they have not been able to identify or grow virus or do contact tracing to show infectivity in 790 people who had come in contact with the 285 patients who tested positive after recovering from COVID. So 3 developed COVID, but there were other sources that could not be ruled out. So they felt like it was not due to those 285 patients. So I'm not going to go into greater detail on that because everybody got that answer correct. So I think I'm done with my slides.
And Irene, this was the study that actually convinced me that the infectivity really, after recovery, they're no longer infectious. And it increased my confidence that we were doing the right thing and cutting back.
Yeah, and it did me too. But this came out in March and it just does not die. People are still saying, oh, we don't know. And JAGS just published an article with 3 cases saying, are these reinfections or still infections? And I'm like, oh,
Mm-hmm.
Yeah.
We're discussing it here.
Right. And you guys all got it right. So I'm so happy. Thank you.
Well, I think it is a point that has all of us puzzled for a long time, because we have seen when we used to use the test-based strategy, we all had these people that were going on, and we were really concerned. And I think when this came out, when the data came out, I think that was a big relief. The other thing that that CDC also said, and I think that probably goes also back to this study, and I am so glad they mention it, is not to retest people who have recovered within a 3 months. I mean, they're limited to 3 months, which is cautious because we don't know whether, how long a potential protective status lasts. But what we've seen too is that people have COVID, then they recover, then they go to the hospital maybe for an unrelated reason and they get retested. And it's like, oh my God, they have COVID positives. And, I think we can stop doing that now. So, so I have instructed people not to retest our prior recovered patients ever again.
Exactly. And let's save those tests for people that need it.
Yeah, just if they need it, and don't include them in anything else.
That is the
hospitals know.
Yeah, that is the inherent problem of checklists, where most of the time checklists help you improve and standardize care and best practices. Well, there's the unintended consequence that you can't get too cookie cutter with geriatric patients. And you can imagine hospital emergency room, which is trying to streamline things for better patient care, have now these checklists, like every patient coming from a nursing home should be done a PCR test right away, right? I mean, not even recognizing that this patient recovered 6 weeks ago. Let's not do it, right? So that's just an inherent problem when you're dealing in a pandemic of this nature, that you're going to have those barriers.
Mm-hmm. Yeah. All right, I've taken up half of our time. I think we need to move on.
Well, great studies. I've had some questions here whether these will be available, and we'll certainly cite them and give the slides also on the AMDA website. And I'm actually hoping to have the studies downloaded on the AMDA website. So Arif, it's your turn now. Go ahead.
All right. I'm so happy in the introduction today, Sabine, you got it right when you say, I have on the panel 3 experienced medical directors. I always cringe whenever you say we have 3 experts. Like, there's no expert in the COVID business here. So thank you for changing your opening remark there. I feel less pressure now.
This is not, it's not a scientific name, but we are bringing science in.
Yeah, there's just so many studies pouring in. Man, I got piled. I wish I could turn the laptop around and show you like all these piles of studies and journals. And I get anxiety. I get panic attacks that I can't read 10% of them. These studies are just pouring in. And which one you click on, and you got limited time for read every day, which one you do not click, and man, it's tough. But these couple of studies which I'm bringing tonight may or may not be related to our conversation earlier on, but I just found them interesting and they answered some questions for me, and so hopefully you'll find them interesting. So the first one here is an interesting study, risk factors associated with mortality among residents with coronavirus. This was just published, I think, a couple days ago, and it's published in JAMA. It's about what's going on in long-term care facilities in Ontario, Canada. What they did was they looked at 627 facilities and found out that there were 43% reported either infection among staff or residents. And they found out that the incident rate ratio for mortality among long-term care residents as compared to community residents of similar nature was 13 times earlier on when they did this analysis. As you can see, the confidence interval 9.9 to 17.3 times the rate of community living elderly. So this is how high risk long-term care residents are. And then quickly, if you see that when they repeated in April 11, the same analysis, and they found out that it had gone sharply up just in a few weeks to 87.3, which is huge, which is I had to kind of really scratch my eyes to make sure that I was seeing the right number. So this is how high the risk we're dealing with in terms of morbidity and mortality and among our long-term care frail populations, for many reasons, which we probably all know really well. The other interesting thing it was the third thing is that the staff, again, we know that already, but this study was able to put a number on it, that after 6-day lag, if you have a staff infected on day 1, by 6th day, that increased significantly a death in the building by 1.17 times. So staff getting infected is actually a mortality risk factor for the residents. So, they were able to show that through their data. And their conclusion was, which we are doing right now, is early identification of risk requires a focus on testing, providing personal protective equipment to staff, and then restructuring the long-term care workforce to prevent the movement of COVID-19 between facilities. I do, so, and this just goes hand in hand with other studies we have seen from Grabowski and Vince Moore and others, is that you could be the best facility in the world. But if you are in a high prevalence community, well, best of luck preventing it. You can ask all those questions, and I'm sure you guys have too. And I have done this screening job in the buildings where you sit in the front and just screen people. I've done that, some of my buildings just to help out, and it just becomes a kind of a norm. Like people, I don't know if people are even reading those questions while they're asking those things, those screening questions. So that's an inherent problem, is that once you start put all these screening processes for the staff, it becomes routine where they have to answer these questions, twice a day. Are they really reading? Are they really answering those questions? So it kind of worries me that we are just asking questions for screening. So I think it's important for us to look for a tool like the antigen test, which has been made possible as an addition to the testing strategy. I know that there's some studies out which are using now the sense of smell as a screening tool also. So I think we do need to compound our screening beyond just asking people questions and doing temperature. So that's what I kind of learned from this study. So I'll just stop here.
About this, and maybe I'm not quite understanding this, but the death rate, or the IRR stands for
It's incident rate ratio. It means what is the death rate ratio for people in the nursing homes as compared to those in the community. So it is 13 times more initially, but it went up to 87 times more.
And why was that? Why did this? Just because more people got infected?
Yeah. More people got infected, and probably staffing issues. I mean, who knows? I mean, it will take us decades to kind of figure this all out.
Huh.
It measures spread, Sabine, and the quickness of that.
Yeah, I think.
And so, as Sarah pointed out, from early on till April, it really skyrocketed. It was almost a logarithmic rise.
Okay.
The other issue is that we first had infections only in older adults because that's where we found them and found people who have died. But then more patients that were younger got infected. So then the ratio of those who had died that were older was much higher compared to the patients who did not die because they were younger, but it was a larger number.
That's a good point.
It's just a ratio.
Okay. All right. I think this just cements many of the practices. I don't think that changed anybody's practice, other than it is just really dangerous to have COVID in your building. It's just, and I think if we need to, maybe this is fodder for our political engagement in this arena, where our patients are just so vulnerable, and we need to spend money to protect them.
And again, I will just highlight is that it's important for us to know what's going on with the staff, and just asking questions is not cutting it. We need objective, scientific ways to do some more understanding, if they have COVID or not. So that was the other point.
Yeah,
I advocated testing of my staff twice a week. This way we would capture anybody who is asymptomatic, because we're screening as well. And not testing patients, because we have not had any positive patients, but we've been very aggressive with PPE early on. And I was booed by leadership in my facility, and they said, you're just fear mongering and you're scaring the families. And I'm like, no, I'm saving my patients. We all need to wear masks. And then in addition to that, I wanted testing twice a week of our staff so that we capture anybody who's asymptomatic. I got testing every 2 weeks, which was good at the time. So we've been testing since March. Every other week.
Who's
paying? It's at the VA.
Oh, yeah.
There's I don't know if you guys, so I mean, just talking about masking, there was an interesting study in, I think it was Nature, published, I think last week or 10 days ago, which basically put a number in terms of how much disease was prevented by use of masks in this pandemic. And I think the number was like ridiculous, like 350 million less infections happened because of masking. So yes, masking actually does work. And then you can translate that using whatever mortality number you want to put there in terms of how many infections prevented, preventing infections prevented how much mortality because of masking.
Yeah, and I think I heard this on the radio, and if everybody in the US was masking, I think we can prevent tens of thousands of deaths. So I think masking, face shielding all of that is, it's not rocket science, but it actually really works. It's cumbersome, but it does. It does.
Washing hands, yeah, washing hands was never
Washing
rocket
hands.
science, and we never did it. I mean, as a healthcare system, we should be ashamed that convincing doctors to wash their hands in hospitals, man, it never worked until there were automation and cameras and sensors, and doctors refused to do that. I mean, with all the training and teaching, you know, doctors should really never really went up more than 50% on hand washing in the ICU. So none of it is rocket science. I think
No.
I keep on saying that this pandemic is different than previous infection control issues because it kind of risks us too, ourselves at this point. So we're taking a little bit more seriously this time.
And so what I'm instituting now is really a multitude of gel stations and hand sanitizing stations, not only in every room, but really within outside every room as well. That's my goal, so that it's really easy to do. After everything you do, you gel, or you do hand hygiene. I think that's something that we can, as medical directors, really push for. And these things are actually not that expensive. Those dispensers, believe it or not, they're not that expensive.
Going to the grocery store, like, I mean, right after you pay, you're looking for a hand sanitizer, right? I mean, this is how quickly this culture has changed, because this pandemic has really threatened us and our lives. And even though it was impacting our residents way many decades ago, we just never got that curious and sensitive about the issue. This is how quickly human behavior changes when things threaten us ourselves.
And that's a good behavior change. So that's the silver lining here for future pandemics, including flu as well. All right, what's your next study?
All right, so let's go to the next slide. Study number 2. I hope people find it meaningful and relevant. This study actually done by Genesis. I was really impressed by this. Dr. Vince Moore has been working with Genesis Healthcare. Dr. Rich Pfeiffer, CMO of Genesis, everyone knows, is also one of the authors. And they actually looked at their 341 facilities in 25 states. So I like this study because it's quite broad, actually. So very meaningful to all of us. And they basically compared what happened in these 341 nursing facilities in 25 states to other infections in the community. Other SNFs other than Genesis also. And all these facilities, they had universal testing. 64 of those facilities had universal testing happening. So what they found was that 34% of these facilities and then 21% of non-Genesis facilities had outbreaks. So just gives you kind of an extent, and this data is a little bit older. I know that this has increased a little bit since then. And then they found out that the biggest 2 factors in regards to an outbreak was really the county prevalence. And I really liked it because they were able to give a number that if you had a difference in prevalence of 1,000 cases per 100,000, or just 1% in other ways, then that would lead to a 33.6% higher chance of having an outbreak. So which was a very interesting number, just to think, put some perspective around it. I think we could use this number in our decision making, for our own organizations. And they also found that a difference of 12.5 cases per facility. So this translated into, a 1% change just in the community kind of really had a significant impact on what's going to happen in the facility. And they found that only bed size was something which mattered in the facility, but really there's no relationship between 5-star ratings or past infection control survey. So I hope CMS reads this with their eyes open and takes notes on this one, and they don't just hell bent upon giving IJs to buildings that have big outbreaks, because honestly, it's not about 5-star quality. It's not about previous history on infection control surveys. It's just your luck of being where you're located and how big of a building you are. And they commented on why having a bigger building would have bigger risk. It's obvious reasons, right? A lot of staff staff shortages and crisis and more admissions from various hospitals, bigger catchment area. So that all made sense. So I thought this was a really interesting study. We knew this concept before, but seen this numbers from a 25-state study, I thought was interesting.
I think this is a good study, waking anybody up who's thinking they are going to escape, and although they are in a big area, in a high prevalence area. I think I've had a few facilities and we're all like, oh, we're going to be good. And, just be aware that, if you live in a high prevalence area, you just have an even higher risk. Did it change anybody's practice in a way? I think we'll still do everything that we should be doing. Would it change anybody's practice as far as relaxing restrictions? Probably not, but I think it just cements that if you have a high prevalence of the disease in the county, you shouldn't be relaxing restrictions aggressively.
Well, you're right, Sabine. Again, for example, right now, how many decisions we're making in the gray area? Like, I mean, as you said, you're going to have testing-based strategy in sicker people. Well, this study tells you that if you are in a big community of outbreak, man, you should go on the other end of, decision making and use test-based strategy and not use symptom-based strategy. As so I think this study kind of just reminds you that you can make some decisions based on knowing what's going on in the community.
Yeah, and maybe in those communities you want to test the staff more often. You can make an argument. I mean, if you're probably pretty okay out there in Cincinnati, but should your community rate rise significantly, you can say, hey, let's revisit this. We should maybe do staff testing more often than every 2 weeks. So I think that's something that I'm taking out of that. The higher the community prevalence, the more frequent the staff testing, if we actually get to do that. So.
If you get more information on the antigen testing with a quick turnaround time, that might be the holy grail. Again, when it also improves its sensitivity.
Yes.
I do want to comment though on a test-based strategy versus a symptom-based strategy. I will say that when we were just doing test-based strategy, we got really complacent with the nursing assessment skills because we were just chasing a test result at that point. When we converted to a symptom-based strategy, we really had to double down on assessments, and the nursing skills had to really take precedence. So that is a plus with the symptom-based strategy.
Sure.
That's a good point.
That's a very good point. Yeah. Yeah, great study. Thank you for sharing it.
Sure. I mean, I don't know if we have time for a third study.
We do.
Okay.
We do.
All right. I mean, unless you want to take any questions also in the panel, I just want to make sure that people have a chance to.
So we have, I've been monitoring the chat function, and I think we're all good. I would love to discuss this study. I think
Sure.
that is
yeah, I really like this study, honestly, because they have this amazing graph, which we'll show in a second. It just caught my eye, and kind of I've been hearing about these things, but to see it kind of in a picture was helpful. So basically, this study is just showing us, which we kind of already know, that COVID is not a once and done thing. I mean, I actually had this meeting in my office where we're using the social distancing, and we have this large boardroom, and we had like 10, 12 people there, and I heard a couple of my colleagues who are not physicians, like, oh, I just want to get this thing and be done with. I'm like, dude, this is not like your flu. This is like diabetes. It could be ongoing chronic issue for you. So that has been more and more, of course, not like diabetes, right? I mean, but the point I'm trying to make is that this is not one and done thing. I know a lot of cases, personal friends, and who are just stuck with this thing. And how many lay media articles you have seen where people are stuck with this disease, with shortness of breath, can't do their job anymore, musicians who can't play good music anymore and all that. So this study kind of highlights that. A study done in Italy where they did something really interesting. 142 patients were assessed after their discharge from the hospital, who were from all different angles were recovered with no testing positive at all. And they tested these people, they did a comprehensive assessment on these people for around an average 60 days after the discharge. And look at this, they found that only 12.6% of the people were completely free at day 60. That is ridiculous. Only 13% of people who could say that are fully recovered. That kind of blew my mind about in this, like, wow, which means that 87% of the people continue to stuck with one or more symptoms. 32% had one or two symptoms, and 55% had 3 or more symptoms at day 60. So this is quite serious when it comes to chronic illness issues. None of these patients had ongoing fever or acute symptoms, but look at this: worsened quality of life was observed among 44%, and they use this interesting scale called Euro Quality of Life Visual Analog Scale. So that's quite significant also. And then if you go to the next slide, you can see this beautiful picture of just shows you which are the things which you're stuck with a higher proportion. You can see fatigue, dyspnea, joint pain, chest pain. Can you imagine living with chronic chest pain for 60, 90, 120 days? Man, that's awful. Actually, my wife's brother got COVID in Pakistan. His recovery now is like 4 weeks out, and he called me yesterday, which left-sided chest pain, which incapacitated him for the whole night. So this is real. And then you can see some of the other symptoms also. So I'm just worried about this, like how this chronicity or chronic nature of this is going to affect my patients with mild cognitive dementia or dementia, and how will they be manifesting it? How well we'll be able to treat these symptoms? What medicines we'll be using for pain there's not many good options we can use anyways. It just kind of worries me that what is going to happen after this pandemic is over, or when this is over.
Yeah, and we've obviously suspended a lot of therapy during this, so you could imagine how much catching up needs to get done with all the fatigue, dyspnea, and all these symptoms that are really just persistent. So it's really an eye-opener.
I had COVID in February. I caught it on a flight from Germany, and it was very, very sick. I even went into kidney failure. And 5 months later, I still am short of breath when I run, and I'm a runner, so I'm in good condition. My thought processes are not as quick, and I don't do multitasking as well as I did before COVID. And it is getting better every week. I notice an improvement. But for example, I usually listen to podcasts at 1.5 speed, because otherwise I get bored and my mind wanders, and then I don't pay attention. So with COVID, I had to slow it down to 1.0 and slowly increased each month by 0.1 speed, and I'm up to 1.4 for many podcasts now. But I'm still not back to normal, and I'm still not back to multitasking like I was, and I'm still not able to run up hills like I used to before I got sick. The fatigue is still there, and this is 5 months out.
Mm-hmm.
Wow, I'm glad you're making recovery, but yeah, that's a tough thing. That's a tough deal, Irene, and I'm glad to hear that you're making recovery. And Sabine, I think maybe at we have so many heroes who really got COVID themselves, and who are AMDA members. And maybe Sabine, that would be my recommendation, to invite some of these heroes and just to hear their stories and how the disease has impacted them in positive and some not so positive ways. So. Yeah,
I think that would be great. And I think being aware of, I really like this study, being aware of what it does to you, and really looking at our patients who were symptomatic with the disease, and how they are doing, and what we can do for them. I guess that's the question. What can we do for those patients other than being aware? And
I really like the comment from this one of the audiences, like Asad Zaman, saying that the chronic complications of COVID will redefine healthcare cost. So I fully agree.
Yep. So I think this is all we have. I think that before we started the webinar, there were some questions also on the new point of care testing, and insofar, has anybody in the audience or from the panelists gotten the Quidel 2 or I forgot what the name of the other one was? Have any of you gotten the antigen point of care tests? Has anybody had any?
I doubt it, because the criteria was just tightened this morning. We got the news that now they're only going to send out 600 equipments, and it's a pretty tough criteria where you have had to have had some deaths recently, some 3 or more new cases, or so it's a pretty tough criteria. But yeah, it'll be interesting to hear if anybody has had any experience with it yet.
Yeah.
Is that the hotspot criteria, basically, just to define yourself as a hotspot so they can send you?
Well, they have the hotspot criteria, but they have added 4 more elements to it now. So I don't remember the top of my head. Yeah, but they just did today. And they said they were going to be only sending it to 600 buildings this week. So it's not going to be more than that at this point.
Okay, that was good. Yeah, when these things get announced, it's going to be in all facilities. It's always like, I think Mike Wesselman said, I believe it when I see it. It's just like, there's always pedaling to be done. But we had a good webinar from the Washington State Society yesterday on these point of care antigen testing. And I think the strength of the point of care antigen testing is that it is point of care, and that it can be done rapidly. And we were just talking about the high prevalence in the community puts you at very high risk. And all of us have seen that one staff member who brings it in, and before you know it, you have 3 dead patients and 10 or 20 infected patients. So I think using that for staff, possibly as you said, a reef instead of those rote questions and the temperature that seems to be never up, or if it's up or down, it's always wrong. This is possibly the future. What the panelists said was interesting to me. Don't invest in a lot of that yet. So don't go out and get 1 million test kits yet, because very soon there will be upgrades to this that hopefully improves the sensitivity, which is not great. And you should not be falsely reassured if there is a negative test. If there is a high pretest probability and the test is negative, you must really reflex to a PCR. But it does have a role in outbreak containment if you need to make decisions quickly and you have positives. And it does have a role in testing asymptomatic staff. And Tony Burgess has given us a citation here if anybody wants to copy that into their browser, the citation for the 600 now test machines that will be sent out. So I want to thank everyone. A very special thanks to our speakers for sharing your expertise with us today and taking the time in your very packed schedule. The papers discussed today and the recording of this grant rounds will be available on the AMDA website. AMDA will continue COVID grant rounds, pearls from your peers, and bring you topics of the greatest interest. I think we have a few topics that we identified. And I think the strength of these grant rounds will and shall always be specific relationship to our space and to our patients and staff. We will see you again in a couple of weeks, hopefully. Until then, be well, and thank you for attending. And thank you, panelists, again.
Thank you so much. Appreciate it. Take care.
Thank you, guys.
Thank you.
Thank you all. Have a good night.
Bye.
Thank you.